Hello, I am the speaker for this morning, and the subject is chronic disease in the older adult. This is myself. I am a former director of the geriatric division at Montefiore Medical Centre and also at Maimonides Medical Centre, and incidentally a clinical professor of medicine at SUNY Downstate, an associate professor of nursing at New York University College of Nursing. The next two slides indicate who are the sponsors of this talk, and this is basically the Consortium of New York Geriatric Education Centres. Here are the objectives for this module, and I hope you'll be able to deal with them at the end of this talk. They are to identify the characteristics of susceptibility to chronic disease in older adults, describe how chronic disease care model is different from the medical model for acute illness, describe the prevalence of chronic disease in older adults, and also describe the trajectory of chronic illness in older adults. How do we define a chronic disease? Well, here are the definitions from the National Centre for Disease Statistics. A disease lasting longer than 3 months. It's usually not preventable by vaccines nor medication, though in a few cases it can be. Rarely do they disappear, chronic diseases, and this is why, of course, they are such a problem. Here is the prevalence of chronic disease in the United States, and note that from 1995 projected until 2030 it is going to continue to rise. And this, of course, is at the same time as the population demographics for the elderly is rising in the same manner. So we're going to see an awful lot more chronic disease than we currently see. You may think that we are at the moment knee-deep in chronic disease problems. They are going to get worse. That is why we are presenting this topic to you today. What are the effects of chronic disease? It affects more than 100 million US citizens, at least 1/3 of the total population of the United States. In the over 65s, 88% have at least one chronic health problem. It may be dominant or maybe less dominant, but a huge majority of those over 65 have problems with chronic disease. And in many instances, it is not being adequately dealt with. The causes are involved in at least 70% of all deaths in the United States, and you will see a slide on this later. And more importantly, chronic disease consumes a huge amount of budgetary healthcare costs. At least 2/3 of all US healthcare dollars are spent on chronic disease problems. This looks at death certification, and the dark colours indicate where the death has been due to the acute reason for the issue on the left-hand side. The paler ones are those where it's associated as chronic disease in the death of the individual, and you will see that in many instances there is as much chronic disease, if not more chronic disease, than acute disease in the cause of death. And again, this is something that I don't think is appropriately realised in medical and nursing teaching. What is it? It's about 2 or 3 years old. The US spends at least in that period over $2 billion on healthcare annually. 0.75 cents of every dollar is spent on managing chronic conditions, and of course that is the major money consuming instance for our budget in terms of healthcare. More important is to be noted that 1/3 of the cost alone is due to obesity, something that is in many instances preventable. How do we deal with this problem? There have been many suggestions, many programs suggesting how to cope with it, how we can reduce it. Here are some areas where we can hopefully ameliorate the incidence and the increasing prevalence of chronic disease in our population. First of all, look at lifespan settings. We need to teach about chronic disease, not just when it occurs, but before it occurs. That means we need to do it in work sites, in schools, and it's never too early to start, in community centres, in health systems, And we need to deal with it at all ages of the life cycle, in infants, children, adolescents, adults, and older adults. That is one way we're going to start to deal with the problem of chronic disease, by promoting health and hopefully reducing the amount of this problem. What are the underlying risk factors? Well, they're well known. You all know them. Tobacco, poor nutrition or inappropriate nutrition, lack of physical activity, excess alcohol, though it must be said that a gentle amount of alcohol has been shown to be of value in prolonging life, and genomics. This means that some individuals have got a predisposition due to their genetic makeup of chronic diseases. We're now being able to map some of this out in terms of the human genome, and this may be how we're going to have to deal with it in the future, but that is very much in the future. What are the priority conditions that we look for in chronic disease? Well, I'm sure everyone in the audience can name at least 2 or 3 problems that you can deal with from personal experience amongst your family, your friends, and possibly yourself. The priority conditions are listed here, and you can read them. Heart disease comes top of the list. Stroke, first, due to the control of blood pressure in at-risk population. Cancer. Cancer is a chronic disease, not an acute disease in most instances. And here again, we're getting slightly better, I say slightly, at dealing with mechanisms of recognizing cancer early or trying to prevent it. Diabetes is a huge problem. It, of course, is associated with obesity, and if we can deal with the problems of diabetes. Diabetes, of course, has other problems of chronic disease. Diabetes can cause a neuropathy, which is a chronic nervous condition. It can cause problems, cardiac problems, which, of course, is also on the list. It can cause visual problems, and we're going to talk about that later. So having diabetes, it can cause renal problems. So having diabetes means that you are likely, or at least at risk, from several other areas of chronic disease. Obesity, we already mentioned. We have an epidemic of obesity in this country. I don't need to remind you of that. Healthy eating, of course, is one of the ways to deal with this, along with exercise. Arthritis. Arthritis is one of the hidden illnesses in our population. We tend to complain of joint discomfort. We tend to think it's something we've got to put up with, and often we do. However, arthritis is a very major problem for many older people, and often is extremely inconveniencing in terms of their quality of life and their pain control. And oral health. Nowadays, many elderly maintain their teeth into old age, which is a new situation. Attention to teeth is important because we do know that poor oral health has a correlation with other major chronic conditions, for example, cardiac disease. Now, let's turn to falls. We know that the elderly population is at risk for falling. And of course, with the increasing number of elderly in the population, we're going to get more falls. We now have many programs trying to deal with this. The results of these programs, of course, is moot. There are some falls prevention programs which have been shown to be useful in terms of limiting the number of falls, or if not limiting the number of falls, limiting the severity of the falls themselves. In other words, maybe preventing trauma due to the falls. However, we're going to have an increase in falls in our older population as it occurs. Many elderly people will fall in later years. The reasons for this is complex and multifactorial. We have problems with balance in later years. We have problems with gait in later years. We have problems with vision in later years. We have problems with our environment, our architecture, and also with our level of mobility in terms of exercise. All of these aspects may contribute to falls. If we can limit the number of falls old people have, we're going to limit the epidemic of fractured hip joints that's occurring in our elderly population, particularly the elderly female population over the age of 80. We're going to talk a little bit about prevention, how to deal with chronic illness. This is a class taking Tai Chi. Tai Chi is one of the few proven ways to be able to prevent chronic disease coming on faster. Those people who indulge in Tai Chi, and you'll notice that most of these individuals in this photo, if not all, are well into the over 65 age group. Most of these individuals will have, as a result of Tai Chi, better mobility, and better posture and also better balance. Tai Chi has been shown to be extremely helpful in terms of maintaining appropriate activities of daily living in later years. And we're going to talk quite a bit about activities of daily living in the next few slides. What other improving behaviours are there? Well, you know them all. Whether you pay attention to them is another matter. Appropriate diet. It's important that we have an adequate diet of the main constituents of protein, fat and carbohydrate, but in the right proportions. We should not overeat. We know that people who tend to eat less tend to live longer. We know from experiments in rats and mice that rats and mice deprived of calories have a longer lifespan than those who have an ad-lib diet. In other words, it can eat as much as they like. Maintain a healthy weight. Old age is not a time to put on weight, though we do find that many people tend to. This may be related to the lack of exercise in later years. You don't in later years stop doing exercise, you need to maintain it. Quit smoking. That's very important. Unfortunately, we find that some ethnic groups are more likely to smoke than others. We tend to find that Asians have a much greater preponderance of smokers than non-Asians. And exercise regularly. I'm going to keep beating the drum about exercise. This is so important for older people. You're never too old to exercise. You're never too old to go to gym classes. You're never too old to go to regular exercise programs. Let's look at some of the chronic diseases. Arthritis. I put this top of the list because, as I say, it's the hidden disease in our older population. Most older people will complain of some form of arthritis, be it neck, spine, joints, wherever. And of course, many of them will self-medicate themselves for it. Arthritis can be disabling in terms of pain, in terms of loss of mobility, in terms of swelling of the affected joint. If one has arthritis, it's important you pay attention to it, and if it becomes inconveniencing, in other words, it starts to impair your quality of life, you need to get help, you need to get advice, you need to get a medical or nursing opinion as to what to do. Cardiovascular diseases. Here the ones are coronary artery disease and stroke. Basically, coronary arteries and stroke are usually associated with hypertension, which should also be on this list. Cardiovascular diseases are the major disease problems one of the major disease problems in our older population. And much can be done now by preventing it by appropriate preventive measures with diet and exercise. Cancer. Cancer is a chronic disease in most instances, and we now know that people who have a diagnosis of cancer have got much better options than they used to have 10 or 15 years ago, and we expect that to improve over time. It will not happen instantaneously, but there are always increases in longevity in relation to cancer treatment. Diabetes mellitus. This is a major problem, as I've already mentioned, and we'll discuss it in the next slide. Obesity, we already mentioned. Osteoporosis. All of you in the audience over the age of 65, if you're women, and over the age of 80 if you're men, must pay attention to the problems of osteoporosis. Osteoporosis occurs generally in the elderly population. There are ethnic components in osteoporosis. We find, for example, that black people tend to have less osteoporosis than white people, and this has been confirmed on histology of their bone structure. Osteoporosis is damaging because it means weakness of the bones, and if that happens, this is where falls become important. If your bones are weak and you fall, you're much more liable to have a fracture. And a fracture can be a pre-terminal event in many instances, particularly in those over the age of 80, and particularly if it's the hip bone that's involved. Osteoporosis, we do know, can be diagnosed early, and treatment can improve it. It's important that all women, once they reach the age of 65, should have evaluation for osteoporosis, and where necessary, intervention should proceed. Dementia and depression. Big problems in later years. Dementia especially. It is the most fearsome diagnosis in later years for many individuals, and particularly for their families. Dementia is really a most all-encompassing illness because it not only affects the sufferer, it also affects the caregivers, and ultimately the caregivers are the ones who bear the extreme burden of coping with somebody who has dementia. Dementia occurs for a variety of reasons. It may be Alzheimer's type dementia, which is the commonest type in the Western world, or maybe due to vascular disease in the brain, which is commoner in some Asian countries. And there may be other kinds of dementia which are diagnosed by appropriate neurological investigations. The end result, however, of dementia is an impairment of your cognitive abilities, your ability to proceed with the simple elements of your daily life. Recent memory goes, and then past memory. You lose the ability to look after yourself, to dress, to toilet yourself, to eat adequately, to look after your bank account, to answer the telephone. And as this progresses, the individual regresses to a childlike state where it requires everything to be done for them. The end situation of dementia is usually a bedfast, incontinent person who is often mute and who requires total daily attention. This takes a long time to develop. From the onset to the end of dementia is usually 9 to 12 to 15 years. It's a very long condition. And once a diagnosis of dementia is made, people tend to associate it almost as if it's a fatal condition, which ultimately it will be. People with dementia, of course, don't generally die of dementia. They generally die of an intercurrent illness, often a pneumonia. And this is one of the areas where death certificates are not very helpful, because dementia may not appear on the death certificate if a person dies from an acute respiratory infection. Depression occurs also in the elderly. The prevalence of depression in the elderly increases over the age of 80. Under the age of 80, it tends to have the same prevalence as those in younger years. Over the age of 80, it tends to increase. A lot of this may be due to bereavement, the loss of companions, and the feelings of solitude that the elderly person has. Again, depression can be treated. It's important that an old person who keeps repeatedly saying, "I'm depressed," is paid attention to. Many people seem to take the attitude that if an old person says they're depressed, this is a fact of life, part of aging. It is not. It requires attention. Back to diabetes. This slide is just really to emphasize what I already said about diabetes. There are about 1/3 of the population in the United States don't know they have it. This is extremely important, extremely dangerous, extremely relevant. These are people who, until it's diagnosed, are going to start having problems with their kidneys, with their eyes, with their coronary arteries, with their nerves. When diabetes is diagnosed, a lot can be done to control it. If it's not diagnosed, of course, that is not possible. Diabetes is also not a problem of younger people. It's a problem which occurs increasingly in older people as well. So everybody over the age of 65 should be checked for diabetes to make sure that any preventive methods can be put into play. Chronic diseases, visual problems, hearing problems, neurological problems. I include Parkinson's disease, epilepsy, and other neurological conditions which are much rarer, and oral health problems. Now let's talk a little bit about visual problems and hearing problems, because these again have major impact on the quality of life of the individual concerned. Visual problems consist of 3 major conditions. Cataract, which is an opacity of the lens, and once recognized and at an appropriate situation can be readily dealt with by simple operative procedures. The next one is macular degeneration. This is important because it leads to retinal pathology, which diminishes the ability of the individual to see adequately. It's important that if vision changes early in later years, you seek appropriate attention. We do know that a visit to an ophthalmologist at an early age, once you are over the age of 65, to get a basic check is very helpful. The third condition in terms of visual problems is glaucoma, and that's an increase in tension in the chambers of the eye. And again, that can be dealt with if it is recognized early enough. Macular degeneration and glaucoma, if they are allowed to proceed, will lead to permanent blindness. Therefore, it's important that individuals who have got early visual problems have that checked out at an early age. All old people, once they reach the age of 65 or 70, should have a basic ophthalmological evaluation. Hearing problems. Hearing problems are again a major problem with many older people, and these may be due to a variety of causes. The first, of course, is wax in the ears. Many older people harbour a huge amount of wax in their outer ear canal. If this is removed, hearing can improve markedly. There have been studies which have shown that up to 33% of hearing difficulties in later years is due to wax in the external auditory canal. Other causes can be due to sensory neural problems, where there is difficulty in the nerve supply dealing with the actual reception of hearing. This may be due to prolonged exposure to high sound, to high volume sound. It may be due to changes in the structure of the internal ear canal. It may be due to changes in the nervous structure of the hearing mechanism. Where there are hearing problems like this, these require evaluation so that any intervention can then proceed. Neurological problems we've talked about. Oral health problems, again. Oral health problems may predispose to other disease problems in the elderly. I've mentioned cardiac problems. They may also be a predictor of gastrointestinal problems. So the health of the older person's teeth is paramount, and again, attention should be paid to this. Now I want to talk a little bit about how we deal with acute illness and how we deal with with chronic illness. The medical model I suggest in terms of acute illness is you diagnose it according to the symptoms and the clinical findings. You intervene by treating it, and you cure it. That is the acute care model, and that should lead to the individual being totally better. I call it the find and fix it mechanism of management. Chronic illness requires a different paradigm. It deals with prevention and intervention and monitoring. Prevent, if possible, issues such as obesity, hypertension, inadequacies of diet, inappropriate diet, excess alcohol, inertia, lack of exercise, lack of intellectual exercise, lifestyle issues. All of these are important and require attention to. And these need to be started early on in the evaluation of the older person to eliminate or at least prevent or chronic disease occurring. Intervene. Intervene for certain specific conditions, and I'll list some of them here. Not all of them. Many of you will have other chronic conditions that you would suggest intervention would be of value. We've talked about osteoporosis. We can deal with that. We've talked about dental care. We can deal with that. We've talked about exercise. Again, we can deal with that. Don't forget foot care. That is very important in older people, particularly those who are diabetic, those who have vascular problems, those who have arteriosclerotic disease. And teeth care. That is also relevant, and we've mentioned why. These maps indicate the age-adjusted population of doctor-diagnosed arthritis in the United States. The one for women is much more dramatic than the one for men, because arthritis is mainly a disease of women. I'm not suggesting that men don't get arthritis. Of course they do. But we tend to find women tend to have it more frequently and for a longer period of time than men. Chronic arthritis affects 21% or more of the whole United States population, and 65% of those are women. 27 million at least suffer from osteoarthritis. I'm sure some people in this audience are suffering from osteoarthritis. Osteoarthritis can affect any joint in the body. The main ones it involves, of course, are the hip joints, the knee joints, the spinal joints, particularly in the neck and the lumbosacral spine, and it can also affect the small joints in the fingers and the feet. So osteoarthritis can have a major impact on joint performance. Let's look a little more about vision. I've already discussed vision with you a few slides back, but this gives you some degree of prevalence of vision problems in the elderly population. And this is now nearly 9 years out of date. About 16% of our elderly population suffers from glaucoma. Macular degeneration occurs in 16% as well. And macular degeneration will lead to permanent blindness unless it is diagnosed early. There are two forms of macular degeneration. There's a wet form and a dry form. Wet form is one that we do something about now, hopefully, if got early enough. Cataracts, people with cataracts in the last year, 44%. Cataracts are almost inevitable in later years to some degree. Of course, not all cataracts require intervention, removal. We remove cataracts when they are thought to be ripe for it, because to remove them too soon would be inappropriate. Hearing. Over 75, about a quarter of us will have some degree of deafness. Those in nursing homes will have twice that amount of deafness. And here are some of the causes. Wax, middle ear disease, which may have occurred earlier in childhood. That causes conductive deafness. And of course, sound has got to be conducted through the ear to the neural components in the internal ear. Or sensory neural problems. And this can be due to excessive noise. Excessive noise over a period of time can ruin the neurological mechanism for interpreting sound. Drugs can cause problems with hearing. There are certain drugs which can cause total deafness. And brainstem lesions. This is because this is where the nerve center for hearing is located. How do we deal with this? Well, we assess, we examine, and then we audio test. The simplest audio testing is the whisper test at the ear, and this can be done at the bedside. If this is positive, then the individual, provided there is no wax in the ear, should be referred for audio testing. By the way, presbyacusis is the term we use for hearing problems in later years. It can have both central or peripheral causes. Now a word about teeth. This is a slide which looks at the percentage of older people who have no natural teeth. Now, when I was young, most people of my parents' generation had their teeth pulled when they reached a certain age, and they spent the rest of their years with their false teeth either sitting in their mouth or on a glass at the side of the bed overnight. Fortunately, we no longer at that situation. We have recognised that dental hygiene can have a major impact on preserving our teeth in later years. And this is important. If you don't have natural teeth, your gums will resorb. That's the calcium in the bone underneath your gums will diminish. And of course, that makes it more likely to fracture. Secondly, people with no teeth don't eat well. You can't chew as readily with gums as you can with teeth, which makes a lot of sense in why you should maintain your teeth. And thirdly, the absence of teeth can limit diets because people will not be able to chew certain things which they would otherwise want to. A soft diet is usually what the toothless person will prefer. We're getting out of that situation, fortunately, and this looks at the number of percentage of people over the age of 65, and the next cohort, 65 to 74, and the next cohort, and the next cohort, who have no natural teeth. I hope to see these levels, these percentages diminish with the passage of time, now that people are able to take better attention to their teeth. Unfortunately, we don't have national insurance to look after your teeth. And this is one of the major problems in older people seeking help, because poverty has a major impact on healthcare in terms of dentition. If we look at those over 65 below poverty who don't have any natural teeth, it is 46%. If we look at those above the poverty level, in other words, those that can afford to maintain regular dental hygiene through an orthodontist or a dentist, we find that that's down to 27%. This is really speaking in the need for a program for dental insurance on a universal model like Medicare for the over 65s. I show you this slide because I found it rather amusing. How on earth would a visitor to the Alzheimer's wing be able to get into it, faced with this maze to get into the appropriate place? I want to talk a little bit about dementia and memory impairment. This is one of the big problems for older people and their relatives. It's what's most 70-year-olds, because they keep wondering, I'm forgetting somebody's name. Does that mean I'm starting to be demented? Now, people forget names at any age. People in their 20s and 30s don't think that. It's only when you get into your 60s you begin to wonder if you're vulnerable from the point of view of Alzheimer's disease and other forms of memory impairment. This slide looks at the degree of memory impairment, and here we're talking about everything from benign cognitive impairment to Alzheimer's disease and other forms of dementia. We're looking at it in the over 65s, and you'll see that in terms of men, 15% have got such problems and 11% of women. If we go up the age scale, and here we're looking at 10-year gap age cohorts, you'll see that it does increase. We find that most memory impairment occurs in the very old. About 33% of men and 31% of women will have memory impairment once they are 85 or over. And this is one of the unfortunate factors of being very old. Now, this means, of course, that the other 66% do not have memory impairment, and that's the good side of the equation. The memory impairment, of course, doesn't necessarily mean that you have Alzheimer's disease. Benign cognitive impairment is a condition where there is momentary inability to remember occasional recent things, and who doesn't have that at any age? However, that may be a predictor for Alzheimer's disease later on. And appropriate testing, psychological testing, neurological testing, or testing from your family doctor and your general practitioner should help to determine just how extensive that is. Depressive symptoms over the age of 65. This is a rather different pattern from the previous slide. You'll notice that again, for the 10-year cohorts from 65 to 84 of depression. It's only over the age of 85 you find a vast jump in the amount of depression in that population. Part of it is due to the fact that many of the over 85s are solitary, and therefore many of their peers have died, their spouses have died, and they don't have too many activities to keep them involved. And these, of course, are antecedent issues in terms of the causation of depression. I want to talk now a little bit about drug interactions. There'll be other speakers dealing with this in more detail, but this is just to give you some background to the iatrogenic effects that can occur with our medications. Matti Mesi will have talked to you about iatrogenesis. And basically what I want to look at here is how often elderly people with drug side effects turn up in the emergency room. The number of over 65 people who visit the ER every year is round about 180,000. About 3.6% of these are due to potentially inappropriate medications according to the Beers criteria. I'm sure most of you will be aware of what the Beers criteria are. Dr. Beers in the 1990s listed a series of medications used in the elderly which were most likely to cause severe side effects or inappropriate side effects. He did it in a nursing home population. It was subsequently updated to look at a general elderly population and has been more recently updated to deal with much more modern medications. However, it should point out that only 3.6% of those who are admitted to the emergency room have drug reactions according to the Beers criteria. 10 times as many have it due to drugs which are not classified as inappropriate in the Beers criteria. And this is because these are drugs which are in common use. Non-steroidal anti-inflammatory agents is one big group. Aspirin is another big group. Anticoagulants are another big group. All of these are often appropriate for the older person, but they are not able to handle them adequately, or they're not able to deal with them in terms of appropriate drug dosage appropriately, and that's why these drugs tend to appear more frequently than those previously recognized as potentially inappropriate in an older population. And of course, our elderly emergency room population is somewhat different from our elderly nursing home population. A little bit about frailty. Frailty is a diagnosis which you tend to make when you see someone. It doesn't have a very defined text of symptoms and signs. I list some here which have been agreed over time by people who do a lot of work in this area. but you tend to look at a person who is frail. You frequently find in a chart, frail individual. Ask the individual who wrote that what they mean by frail to see just if they can define it. It's often not easy. Here are some of the components of the clinical frailty syndrome. Anorexia, a waning of the appetite. Sarcopenia, that is muscle wasting. Muscle wasting tends to occur in later years unless the individual exercises regularly. We do know that sarcopenia can be prevented if a person has adequate exercise, particularly weight training exercises. Sarcopenia occurs when the muscle fibers are replaced by fibrous tissue. Osteoporosis, we've talked about that and we've talked about how to deal with it. General unexplained fatigue. An older person may often complain of general fatigue, particularly in the very advanced years. I have a 96-year-old lady who keeps telling me, I'm terribly tired all the time. And she has got anorexia, she's got sarcopenia, she's got osteoporosis, she's got gait impairment, she's got risk of falls, she falls into clinical frailty syndrome. Risk of falls, again, that is a component of the clinical frailty syndrome and is often allied with impaired gait. One of the ways of determining a person's level of frailty is to determine just what their gait is like. Can they do a standard get up and go test? Or if they can't, that's important. And poor physical health, poor general physical health is another component of frailty. Why do people get frail? Here are some of the thoughts. It may happen at any level. These are areas that are affected in the aging of the human body. There are molecular changes in terms of the constituents of our cells. There are cell changes. The tissues that make up our organs undergo changes so that the amount of actual active cells may diminish and the amount of active non-active tissue may increase, for example, fibrous tissue. There may be hormonal changes in later years, and again, this may affect the frailty syndrome. And immunological changes. We do know that certain immunological components tend to increase in frail older people, and this has been demonstrated several times on adequate lab systems. Now, I want to talk a bit about the trajectories of disability in the last year of life, because disability is important to recognise, and we don't seem to do much in the way of how to determine how long a person is going to be inconvenienced by impaired activity. This relates to a paper that was published about 18 months ago in the New England Journal of Medicine, and it looked at trajectories of disability. By that I mean the rate at which a person becomes disabled. What happened here was they looked at how individuals over 2 years tended to show disability. They looked at people who had these problems: cancer, advanced dementia, organ failure, and the organs that were in failure were the heart, the lungs, the kidney, and the liver. They looked at frailty, as was demonstrated by regular functional assessment, and the regular functional assessment was activities of daily living, something we all know about and should always utilise in terms of our older, frail patients. They looked at sudden death, people who had none of the above problems and who suddenly died, and other conditions meeting none of the above. And what they tried to do was look at the graph of frailty from the entry to the study to the end of the study 2 years later, at death. The level of disability was determined according to the patient's, the subject's, activities of daily living level. From these levels, 5 groups of disability could be identified. No disability at all. Catastrophic disability, where it happened rapidly. Accelerated disability, where it proceeded over a uniform manner. Progressive disability, which happened again in a more uniform manner. And persistently progressive disability, where it was there from the beginning of the study to the end. As I mentioned, the follow-up for 24 months until the death of the individual. What was the result? Those who had no disability had minimal ADL loss before death. In other words, it's the way we all want to die, with no disability. Catastrophic disability had minimal ADL disability until 2 weeks before death. What kind of individual is that? Somebody's been perfectly fit up until they suddenly had a massive heart attack, a massive stroke, something like that, and then die soon thereafter. Accelerated disability started with no disability, but rapidly advanced from nil to major ADL limitations. So they started off nil, with no problems, but rapidly accelerated to major disability and death. Progressive disability were those who started off with limitations. These were those who were already impaired. They had 1 ADL limitation at the entry of the study, and this accelerated rapidly to 3 at the time of death. And persistently severe disability started at the beginning of the study with at least 3 ADL deficiencies, and this slowly increased until death at 24 months. They started at a higher level of disability and gradually increased until death at 24 months. Now, why do I mention this to you? Because it's important in terms of determining disability and to be able to prognose on it, that you have some idea of what the level of disability is going to be like, what the curve of disability is going to be. It allows to plan in terms of advanced directives, what caregiver needs are going to be, and so on. Now, I want to talk a little bit about care coordination. This is extremely important. Other speakers will talk to you about this, and I'm sure all of you in this audience have got your own views as how this is bad and how this can be improved. Now, I want to talk about care coordination between 3 different groups, between the provider and the patient and the family. That's the one we tend to think of as being most relevant. Between providers, and there are big gaps here, and between facilities, and also big gaps here. Let's look at this. The problems are, as I see it, the narrow focus of providers. We tend to find that providers tend to focus on the chronic or on the acute illness they've been dealing with in terms of the patient. And at discharge, they don't tend to go into much detail of the chronic problems that were still there when that individual was in hospital or in the clinic. This is a big gap which needs to be dealt with, because if the individual provider does not give that information to the patient and the caregivers, then there is going to be a lack of appropriate care, a lack of appropriate prevention. Non-notification of abnormal results. Nationally, up to 1/3 of patients are not notified of abnormal results. Now, I'm sure all of you are aware that your doctors are doing that very adequately, but quite a lot of people are not doing that. And of course, that is not very helpful, because what's the point of doing tests if you don't tell the patient what the results are? And if you don't tell the patient what the results are, and they're going to pay attention to what you tell them, they should do in relation to what was found. Unclear recommendations. This is a major big problem. We find that 2% are unclear as to what they were told by the healthcare provider. The healthcare provider may tell the patient what he or she wants the patient to do. The patient may understand to some degree what is being received, but their interpretation of that may be very different from what the healthcare provider wants. And the family may have a very different view of it as well. So there may be conflict between the family and the patient, and conflict between the provider, the patient, and the provider and the family. It's essential that these very clear recommendations are made, that they are written, that they are substantiated, and that they are monitored. This is where a lot of chronic disease problems are unmet. The last one is a major issue. 18% of patients receiving conflicting advice from different physicians. We've all seen this. And of course, this is often due to the tunnel vision of specialists as opposed to generalist vision of generalists. Specialists will look at the problems of the patient in relation to the organ system with which they are familiar, with which they were consulted. But they've also been not necessarily paid attention to the other components of the patient's chronic illnesses. This is where there needs to be a major improvement in terms of communication. Where there is different advice from different physicians, the individual should contact the different physicians to ask why they are getting different advice. Because a lot of physicians are going by guidelines from their own specific body, such as the cardiology body, the gastroenterological body, rather than the general views of generalist physicians. And that, of course, may be helpful, but may not be helpful. How do we deal with chronic illness? Here, in summary, is how we deal with it. We deal with it with case management, case-by-case management. We also deal with it by disease management. We look at the different disease issues. We should also deal with other forms of management, which I don't mention here. There are issues of dealing with the environment, there's family management, There should be team effect, of course. The individual should be followed by a team who deals with the different aspects of need. And it's no use having a proactive management program unless you monitor the interventions. Unfortunately, monitoring of interventions is not an area that the federal government pays too much attention to in terms of reimbursement. Therefore, it is much less frequent to occur. But monitoring of interventions is the only way of ensuring that programs for betterment are being followed and that the healthy individual will continue to be maintained. Monitoring is not just maintaining the status quo. In many individuals, if you're not monitored, they will regress. Monitoring is a means of ensuring that they're kept up to the level that was achieved by their hospital, nursing home or clinic admission. The problem with chronic care, as I mentioned, is that it is not adequately reimbursed. Acute care is a very reimbursable commodity. Chronic care is not, and this is one of the major difficulties, which is surprising, given that Medicare pays 70% of its funds on dealing with chronic care. These are some of the sources I used in terms of my talk, which I hope you've enjoyed. And this is one of the mentions, the apple a day, that keeps the nurse or the doctor away. Thank you.